Hello, my name is Dr. Sandra Jan. I'm an adjunct clinical affiliate at the University of Texas at Austin School of Nursing and a psychotherapist in private practice in Austin. I'm also a proud member of the Psych Congress Steering Committee and our Psych Congress family. We hope everyone is staying healthy and safe during these challenging times. I'm delighted that you've joined us today as we continue this educational video series addressing tardive dyskinesia and coping during the COVID-19 pandemic. This program is approved for 0.25 continuing education credit, and the series is supported by educational grants from Teva Pharmaceuticals and Neurocrine Biosciences. It's my absolute pleasure to introduce our guest expert today, Ms. Amber Hoberg. Ms. Hoberg is a psychiatric nurse practitioner in private practice in San Antonio, Texas, and is a national leader in psychiatry. She is highly influential and an excellent clinician as well as educator. We are fortunate to have her with us, and today she's going to be discussing a topic that is especially important during this pandemic: telepsychiatry, approaches and adaptations for TD assessment. We so appreciate you being with us today, Amber.
Well, thank you so much, Sandra, for having me here today. I appreciate being part of this.
You know, Amber, so many clinicians have transitioned to telepsychiatry in response to COVID-19. We've all experienced the pluses, the minuses in making the transition. But what about the challenges that we as clinicians may face when we're using telepsychiatry in assessing for TD? I'm wondering, what have you experienced in your practice setting?
Absolutely. Going from being in person to now being online, some of that, one, is making sure our patients are comfortable. In my practice, some of my patients have not been comfortable in front of a computer or in front of a camera. And so a lot of that is education and talking to my patient about, hey, it's just me, and we're going to have a conversation the way that we've always had that conversation. Secondly comes, making sure that things are right on the other end. So before my assessments, I make sure that the camera, is set up correctly. And also, another big thing is your moderator. Who is the person on the other end that is helping you? I make sure to spend quite a bit of time talking to my moderator about my different assessments and the things that I'm going to do to assess for tardive dyskinesia, so that they are versed in, if the patient's having trouble, how to help them navigate through that. Also have the moderator sit in the chair and make sure that the camera angle is appropriate. I want to be able to see all areas of where tardive dyskinesia can affect, because during my assessments, I do an AIMS, an abnormal involuntary movement scale, in order to really identify tardive dyskinesia in my patients. That is absolutely something you can do by telepsychiatry if you have those things in place. They can be very challenging, but if you absolutely set it up early and make sure that you have good communication with your moderator, and that they can help you do some of those things on the other end that maybe the patient can't do, or that you can't be there physically to do, can be very, very helpful in identifying tardive dyskinesia and recognizing it in your patients.
This is such practical, useful information for our viewers. I really like what you said about having a skilled moderator on the other end to really help you in doing an accurate assessment.
Absolutely. It's super important to have that. It's important that you work with that moderator. Make sure that they understand the questions that you're going to be asking. And, hey, I'm going to ask them to maybe hold their hands out in front of them, or, tap their fingers like this, and if a patient has trouble doing that or seeing me on the screen, having that moderator on the other end that knows what I'm asking for and how to assess for it can model that for the patient and help me really get a clear picture of what's going on as far as movements are concerned.
You mentioned just a moment ago some of the challenges that you faced with the AIMS when conducting an assessment via a telepsychiatry platform. And because this is such an important issue for our viewers, would you share with all of us how you've modified the aims in that particular format, telepsychiatry, telemedicine.
Absolutely. It can be very difficult sometimes to do a full AIMS, on a patient via telepsychiatry, because again, we're not there to physically manipulate the patient to check for rigidity, or we're not there physically to be able to, do these things with the patients that we need them to do. But again, if you're simply focusing on some of the main parts of the AIMS, which is focusing on, again, 5 parts of the AIMS focus on the face. That is absolutely something you can see in telepsychiatry. Again, making sure you're activating. Activating is super important. So getting them to do some kind of physical thing, where I talk about the tapping of the fingers, or what I call turning the light bulb. That's another one I call it, where you kind of wave the hands, or even just simply asking them to hold their arms out in front of them. I ask them to move their chair back and put their arms out in front of them. And then I talk to my patients. Some of my patients don't, can't count backwards. If they can, great. If they can count backwards from 100, or say the months of the years backwards, please do that. But if the patient can't do that, simply ask them to tell you 3 things about themselves that you don't know. That actually gets your patient's mind off of, controlling these movements, and you're going to start seeing things come out as they're starting to tell you these things, and they're doing the different maneuvers that you're asking them to do. So I simply watch their face. Do I see any movements in the eyes? Do I see any movements in the upper part of the forehead, up into the cheekbone, their mouth? I actually will do a specific one on the tongue that I'll talk about in a minute, but I absolutely watch their face. Again, when I know, every appointment I do, I make sure to assess the lower extremities as well. So I'll ask my patients to take their shoes off, when they come in, so that I can absolutely assess their lower extremities. Because again, when I'm activating the patient, not only can I look here in the face, but if I have the angle of the camera correctly, I can actually look at their feet as well to see, do I notice any movement associated with that? Again, if I need to assess rigidity, I can ask my moderator on the other side, who I have trained to be able to show me rigidity, or to tell me if that is there. But for the most part, that can be very difficult to assess because you're not there. But it's very easily doable to modify the AIMS and to be able to do one of these in your telepsychiatry practice. It's something I have implemented, and doesn't take me longer than a minute or 2 to do. And it's just part of my everyday practice. If a patient is on an antipsychotic medication, or has a history of being on an antipsychotic medication, I make sure to do those things so that I don't miss that in my patients.
This is really empowering information for all of our Psych Congress family, knowing that we can make the modifications that you just talked about and still do an appropriate assessment for our patients. Amber, I find best practices to be very important to our work as clinicians. Would you take a moment and share your top 5 best practice recommendations for the assessment of TD when utilizing telepsychiatry?
Absolutely. So I do have 5 best practices that I follow. One is, before I see my patient, I want to look at the treatment regimen. What is their regimen entail? So again, are they on an antipsychotic medication, or are they on an antiemetic medication, one of those medicines that can cause tardive dyskinesia as well? Also, if they're not on one currently, what is their past history? I've had plenty of patients that have schizophrenia that have been on antipsychotics in the past, but maybe not currently because of their age or something different. So absolutely looking at their treatment regimens and what they are on. Secondly, the thing that I always make sure is look for risk factors. Does your patient meet risk factors? Age is a factor. People over the age of 60 have a greater percentage rate of developing tardive dyskinesia. Also, do they have, what is their gender? Are they male or female? That also sometimes can play a role as well. Cumulative exposure to an antipsychotic. What does that look like? How long has a patient been maybe on one agent, or maybe they've been on several different antipsychotics for a prolonged period of time. Also, what is their diagnosis? So, again, major depressive disorder, bipolar patients, they tend to be a little more higher risk. So I assess my patients for that. The higher the risk, again, doesn't mean I'm not going to do them on my other patients, because I do. but I pay attention to that because I want to make sure I really focus on those patients a great deal to make sure I'm not missing anything and not really skimming over anything. Thirdly is doing, my modified aims that I talked about earlier, making sure that I activate my patients and really assess, making sure I'm really looking for it. And secondly, on top of doing that modified aims, it's also asking questions to your patients. What is going, if you notice movement, how long has this been going on? How long have they been having this problem? And then also assessing the impact to that patient. How problematic is this for that patient? Not just how long, but how problematic. Do they have problems feeding themselves? Does it cause them problems dressing or grooming themselves? That's really important to assess that impact. Fourthly, making sure that after I get the AIMS score, along with the impact of that patient, it's using FDA-approved medications like VMAT2 inhibitors to appropriately treat tardive dyskinesia. And then fifthly, it's continuing to monitor the patient and continuing to make sure to stay on top of, if I'm treating the patient with a VMAT2 inhibitor, are they improving? Do I see great strides and great improvements with what I'm doing? Or if they don't have any movement or something I'm just monitoring, that I'm doing that at regular intervals, making sure that I'm catching tardive dyskinesia early and treating it, because that's the best thing for a patient to improve their quality of life.
Before we say goodbye, Amber, I'm hoping you'll share with us your top 3 takeaways from our conversation today.
Absolutely. Well, there was a lot of information covered today. The top 3 takeaways that I have is 1, making sure to work with your moderator on the other end, making sure the camera is positioned appropriately so that you can see your patient, and also working with them and educating them on how they can help you. 2 is making sure we're really assessing tardive dyskinesia in patients. While we may not be able to do a full AIMS, we can do that modified AIMS that I talked about, where we look at the areas that we can see via telepsychiatry and then really activate your patient to notice and see if you see movement. And then 3, absolutely make sure that if you notice movement in your patient, that you talk to your patient about the impact that tardive dyskinesia may be having in their life. And then using the FDA-approved medications, the VMAT2 inhibitors, to treat where appropriate.
I know, Amber, that this information is going to be so valuable to our Psych Congress viewers. I can't tell you how glad I am that you joined us today.
Well, thank you so much, Sandra, for having me here today. I really appreciate being part of this and so glad that I could help others in getting this information to them.
Well, in closing, we wish all of you and your patients the very best. Goodbye for now.